going to discuss histiocytic disorders and Langerhan cells histiocytosis. Now, the thing is that it's a very difficult to understand topic for everybody because you don't understand the basics. So, let's go to the basics. Hematopoiesis is when you have a multipotent stem cell which becomes a myeloid stem cell. Now, the myeloid stem cell is also called a CMP, common myeloid progenitor, or the lymphoid stem cell. And then the lymphoid stem cell will form the lymphoblast. At this stage, you have, you know, ALL, where you can have B lympho, uh, PALL, TALL, or NK cells. Okay, and here, and the myeloid stem cell stage, from the myeloid stem cell can become either a WBC, megakaryocyte, megakaryoblast, granulocyte, or monocyte. Now, the myeloid stem cell if it goes into the dendritic cell precursor, it is called a MDP, monocyte dendritic cell precursor. Now, what you need to remember is that when you have these cells in the blood, it is called a monocyte. And when these cells come into the tissues, it's called a macrophage or a dendritic cell. Okay, like here, now we need to cover this really difficult topic in a very simple way. So start with what we know. We know that the common myeloid progenitor cell, okay, the common myeloid progenitor cell is if it is having a neoplasm, it would be AML, correct? And then you treat it with uh, cytarabine and daunorubicin, correct? For the AML induction protocol, for example. Now, if you have the granulocyte macrophage progenitor, okay, there again it is AML. Okay, now you see as we come down in the differentiation lineage, okay, then you have the monocyte dendritic progenitor, progenitor, okay. Now, when this monocyte dendritic progenitor here, monocyte dendritic progenitor, MDP, monoblast MDP, when this starts proliferating, we get a histiocytic sarcoma, monocyte and dendritic progenitor, and this would be in the M group of classification. Okay. Now, if you have monocyte, a monocyte which is proliferating, you have CMMOL. That's why it's very confusing. You have chronic myelomonocytic leukemia. Okay. And if you have a macrophage which is proliferating in a benign state, it is juvenile xanthogranuloma because macrophages cause granulomas. Now, what's very interesting is that you need to know this pathway where this is a lymph node, and in the lymph node, you have the medulla of the lymph node, and in the medulla of the lymph node, you have the antigen presenting cell, which is usually either a macrophage or it could even be a T, a T lymphocyte. So in the medulla, okay, and this is the medulla, and here is the sinus. In the sinus, you have more macrophages. In the medulla and the paracortex, so here you have an antigen presenting cell. It comes to the medulla and it goes to the cortex, presents it. So if you slice the lymph node in different areas, like if you slice the sinus of the lymph node, you will find a lot of histiocytes or macrophages. So if there is proliferation of a bulky lymph node with sinus histiocytosis, you should say it is Rosai-Dorfman disease. Okay. And if you are talking about systemic foamy histiocytic infiltration, it's called Erdheim-Chester disease. Now come down. Okay, now so we have the granulocyte macrophage progenitor, the monocyte dendritic progenitor, monocyte dendritic progenitor can be in the bone marrow, it can be in the skin, it could be anywhere. Okay, and then you have the common dendritic progenitor. So after you come into differentiation, your macrophage dendritic progenitor. Okay. So when you have the common dendritic progenitor, it can go into one out of two pathways, pathway A or pathway B. Pathway A will be plasmacytoid dendritic cell and pathway B will be pre-dendritic cell, classical dendritic cell pathway. So if you have a malignancy in the plasmacytoid stage, you have BPDCL. And if you have a malignancy here in the classical dendritic stage, you have a Langerhan cells histiocytosis. If it is in the follicle, if it's proliferating in the follicle of a lymph node, you call it follicular dendritic cell. If it is interdigitating, you call it malignant interdigitating. And if you have clonal, not clonal, but if you have overactivation of these macrophages in the periphery, then you have HLH. Okay, so this is how you have to understand the histiocytic pathogenesis, histiocytic disorders pathogenesis. So if you have the lineage, now let's talk about. So if you're talking about the CMP, the common uh, myeloid progenitor to the granulocyte myeloid progenitor, so then you are talking about CMM model. If you are talking about the monocyte, common monocyte dendritic progenitor, you are talking about histiocytic sarcoma, and this would be in the M group. It is very premature. Okay, monocyte dendritic. And then if you're talking about monocytes, then you're talking about CMMOL. If you're talking about dendritic cell, which is lower down, monocyte dendritic. If you're talking about dendritic cell, are you talking about immature, premature plasmacytoid dendritic cell? Or are you talking about a pre-dendritic cell, the classical dendritic cell proliferation, which is L group and M group? Okay, and L group is Langerhans and histiocytosis. And if it is here follicular and interdigitating, they put it in the M group. And if it is peripheral, uh, you know, hemophagocytosis, HLH. Now, in Langerhans cells histiocytosis, you need to understand that it is coming from the bone marrow, then going to the blood, then it is going to the target organ, like liver, for example, the liver or like any target organ. Okay, so it depends on which stage you get the hit. If you get the hit, as in if the proliferation happens in the bone marrow stage, then you're talking of a high risk Langerhans cell histiocytosis, which is a multi-system disease. If the clonal proliferation happens in the blood, it would be multi-system disease, but it would be low risk. And if the dendritic cell starts proliferating inside the target tissue, it is a low risk Langerhans cell histiocytosis, which would be a single lesion disease. So you have the hematopoietic stem cell, you have the circulating myeloid precursor, you have the tissue restricted precursor, and you have the tissue resident dendritic cells. So if you have the hematopoietic stem cell stage where you are having the dendritic cell proliferation, you have a high risk. Otherwise, if you have you can have a low risk or you can have a single lesion. So again, the same concept, bone marrow and embryonic precursor. If you are having, you see, macrophages could be proposed to come from the fetal liver, and then you can have the embryonic precursors to form macrophages as well. Now, the thing is to understand this better, you need to know which stage we're talking about. So if we're talking about a plasmacytoid dendritic cell proliferation, we're talking about BPDD. If we're talking about monocyte, then we're talking about CMMOL. If we're talking about dendritic cell, then we're talking about LCH. So I hope that gets clear. Now, the same thing, to understand better, we should also know the IHC. Now, the IHC over here, which is important to understand, is that which antigen are we talking about? Okay. So when the dendritic cell comes into the dermal subset, usually, or inside the tissue or inside the bone, which is very thin, then you get CD1A. Most most dendritic cells are CD11C positive. CD123 is positive in activated macrophages. That's why an activated macrophage could be, there were two types I told you, right? Plasmacytoid or the classical one, macrophage. So if it is the plasmacytoid, then you'll have CD123 positive. Okay, so S100 is very specific for Langerhans, and this is how you would approach the IHC as well. Okay, so with all of that context, how will you manage it? So again, you look at if it is single system involvement, unifocal or multifocal. If it is unifocal, you do local therapy, you can give intralesional steroids and you can do curettage. If it's single system, multifocal, then if it is so what you will do, you will manage it same as multi-system non-risk organ. So multi-system without risk organ involvement, you will give vinblastine, vinblastine 6 milligram per meter square for 6 weeks. And then we give prednisolone for 4 weeks because steroids will kill these cells. If it is multi-system with risk organ, you will still blast and prednisolone, and you will continue mercaptopurine because of the risk. If there is CNS involvement, neurodegenerative, treated like AML, almost cytarabine based protocol. And then if you're talking relapse refractory, cytarabine or targeted therapy, a lot of these have BRAF positivity. And then you can have supportive care over here. So that's how you will manage Langerhan cell histiocytosis. That's how you will diagnose Langerhan cell histiocytosis. And then you also need to know that it's a MAP kinase pathway. If you need to overview the classification of histiocytic disorders, look at it as like in the way we derive it like how we did, but this is the correct classification, which is L group, C group, R group, M group, and H group. So if we're talking L group, C group, R group, M group, and H group. So L group is Langerhans cells and Erdem-Chester disease. C group is cutaneous and juvenile xanthogranuloma and benign cephalic histiocytosis. R group is Rosai-Dorfman disease, which was seen in this uh, sinus of the lymph node, and the lymph node will become very high. M group is very precursor histiocytic sarcoma, interdigitating and follicular dendritic sarcoma. H group is HLH. So this is how you classify and treat histiocytic disorders. Thank you.